Hi, everyone. I'm Dr. Ashley Bassett,
And I'm Dr. Catherine Logan.
and welcome to Overtime with the Sports Docs. On each of these mini episodes, Catherine and I chat about a new article or new surgical technique in the field of sports medicine. We'll give you our quick take on the most recent data and how this data will impact our practice. Today, we're chatting about recurrent patellar instability and specifically the risk of progressive cartilage damage in the setting of repeat patella dislocation events. We're going to review an article from the August 2024 issue of AJSM titled, "The Number of Patella Dislocation Events is Associated with Increased Chondral Damage of the Trochlea." This study uses data from the Jupiter cohort, which stands for Justifying Patellar Instability Treatment by Early Results. The authors ask a clinically critical question. Does the number of dislocations matter when it comes to early cartilage damage?
So, we've known for years that patella instability is associated with cartilage injury to the patella, to the trochlea, and the lateral femoral condyle. But we haven't clearly understood whether repeated instability events, or more specifically, how many of them, worsen the cartilage damage. And this is a huge issue clinically. We often treat first-time dislocators non-operatively, but what happens when instability becomes recurrent? Is cartilage silently deteriorating while we are waiting?
So this study was a large prospective multi-center cohort study using the Jupiter database. It included 938 knees with a mean age of 16 years old, and the cohort was 61% female. So your classic adolescent instability population. Patients were grouped by number of dislocations into three groups. So group 1 was 1 dislocation, group 2 was 2 to 5 dislocations, and group 3 was greater than 5 dislocations.
At the time of patella stabilization surgery, the cartilage was evaluated directly, so either arthroscopically or open. The cartilage disease was then graded using the International Cartilage Repair Society, or ICRS, classification.
So for our listeners, let's quickly review the ICRS classification. So grade 1 includes superficial lesions such as cracks and indentations, but no significant loss of cartilage thickness. Grade 2 includes partial thickness cartilage loss less than 50%. Grade 3 includes partial thickness cartilage loss of greater than 50%. And grade 4 is a full thickness cartilage lesion. So for the purposes of this study, grades 2 through 4 were considered abnormal.
Okay, so let's talk about the study results. The first pertinent finding was that overall cartilage injury is common. 61.8% of knees had a cartilage injury at the time of surgery. The most commonly affected areas were the patella at 53%, followed by the lateral femoral condyle at 12.5, and the trochlea at 11.6. So cartilage damage is already common in patella instability patients. I totally thought the trochlea number was going to be higher.
Me
Did you?
too.
I don't
Yeah,
know.
that's very
Yeah.
interesting. But we're coming up on
Okay.
some interesting points
Sure,
about
sure, sure.
trochlea.
Yeah.
So the next finding to me was very interesting. So
Okay.
the authors reported that patella cartilage damage did not increase with more dislocations. So to me, this was really unexpected and quite surprising. There was no difference
Yeah.
in the presence or severity of the patellar cartilage lesion depending on the number of dislocations. So patellar cartilage damage is common, as Catherine just quoted, I think it's 50%, and it may occur early, possibly at the first instability event, but it does not seem to progress with repeated instability events.
Okay, so we'll get to the trochlea now. So, trochlear cartilage damage did increase significantly with recurrent instability or more dislocations. So, in patients with one patella dislocation event, 7.6% had trochlear lesions. This increased to 11% in patients with 2 to 5. And here's the major finding. In patients with greater than 5 dislocation events, 19.8 had trochlear cartilage lesions. So further statistical analysis found that greater than 5 dislocations was associated with a threefold increased odds of trochlear cartilage injury. And that was a clinically meaningful difference.
Yeah, and there's more. So combined patellar and cartilage,
Yep.
combined patellar and trochlear cartilage lesions were more common in patients with greater than 5 dislocations. So this suggests that recurrent instability may evolve into multi-compartment or bipolar cartilage damage. So what does this mean biomechanically? Well, the first dislocation often creates shear forces across the medial patella, but recurrent instability likely results in a different pathophysiology with repeated abnormal patellar tracking, recurrent impact of the patella against the trochlea, and progressive cartilage overload over time.
Exactly. So early on, you injure the patella. Over time, the trochlea becomes the secondary victim, and trochlear cartilage damage is harder to treat and may have longer, or I should say, greater long term consequences. So, clinically, what are the implications of this? So, this is where it gets really important. The study concludes surgeons should be cautious regarding prolonged non-operative treatment in patients with recurrent instability. So, let's unpack that.
Yeah, so first dislocation, non-operative management is reasonable in many cases. Catherine, I was just having this
Yeah.
discussion with one of my patients today. He's got elevated risk factors for recurrent instability, and I hope we don't
Yeah.
get in trouble for sharing this, but he's got a trochlear dysplasia, an elevated TTTG,
Sure.
but it's his first dislocation. He's a high school senior. He doesn't want to have a TTO and an
Big
MPFL and
surgery.
be out
Yeah.
for the whole year. So we're managing him non-surgically. Is that the correct answer? I think so, but I still think it's controversial. Second or third dislocation, we need to start thinking carefully. 5 or more, at that point, I think we're
Yeah.
allowing progressive cartilage injury, particularly to the trochlea, as you just highlighted.
Totally. So in my clinic, I feel like this changes my counseling conversation. That you can very clearly say each instability event might increase or really will increase your risk of permanent cartilage damage. And there's definitely some urgency that's created with the incident. As you discussed with the patient you were just referencing, like you can't always just because the literature says this, there's also real life and we have to work with what's happening in people's lives. But, the counseling is so important.
Absolutely. And I think you made a really good point there. And we're talking about our high school athletes. We really should touch on why this matters in adolescence. So the mean age in this study was 16 years old. So these are young athletes. They have high cartilage healing potential. They have long athletic futures, long futures in general, and a long lifetime risk of patellofemoral osteoarthritis. So allowing 5+ instability events before intervening is likely setting them up for early joint degeneration.
All right, so let's just chat about the limitations of the study because there's always limitations.
Mhm.
So, first, it's cross sectional, so we can't prove causation. We also don't know the timing between the dislocations, and we also don't have the data on what was their TTTGs, so their trochlear dysplasia or patella alta. So, the things you're referencing before, like making them more risk, they have greater risk factors based on their anatomy. And that obviously is going to play into the risk of cartilage damage. So, regardless of any of these things, the association is strong and it's certainly clinically relevant.
Exactly. So let's wrap it up with some pearls for our listeners. So 1, cartilage injury is common in patellar instability. 2, patellar cartilage damage may occur early. 3, trochlear damage increases significantly after greater than 5 dislocations. 4, recurrent instability is not benign. And 5, delaying stabilization may increase long-term cartilage risk.
Okay. So, final takeaway, how many dislocations is too many? So, based on this study, 5 appears to be a definite tipping point for trochlear damage. Recurrent instability is cumulative trauma, so we cannot forget that. But cartilage does not forget.
Exactly. I was a little surprised by this
Yeah.
paper with the 5 dislocations. So my practice, it's
Yeah.
like first time, everyone's non-surgically unless really high risk factors and they want
Yeah.
to proceed or loose body, right? But otherwise, second instability event,
Yeah.
I'm talking about surgical stabilization, including TTO if
Yeah.
needed. I don't know that I'd let someone get to 3, not necessarily
Bipolar.
5.
Yeah.
What are your thoughts on that? What's your
No,
approach to it?
I agree. I think it's especially when you start to deal with bipolar and trochlear lesions, as we know, the treatment options become, less, or the outcomes from those treatment options just become less of a slam dunk. So
Exactly.
I think it's, we always have to be thinking about what's going on with the patient's life and what they're dealing with as particular to athletics. But, it just, if it was my kid, I'd be like, we're not waiting. There's
Yeah.
just too much damage happening you're going to be that 40-year-old that comes into clinic and we're like, ooh,
Yeah.
seeing terrible, terrible osteoarthritis progression.
Yeah, that is such a bad problem to have. Instability where
Yeah.
they're still feeling that shifting because they have chronic
Yeah,
instability, but they have literal bone on bone
totally.
patellofemoral osteoarthritis. That is such a hard problem. And as you said, it's always someone in their late 30s, early 40s, and it's just it's a
Yeah.
problem that you want to take a time machine back and
Yeah.
intervene at the second dislocation. But yeah,
Yeah.
so I think this is really interesting. I think it's a great paper. I think it's definitely data we can share with our patients. So I think this is awesome.
Yeah. Agree.
Thank you for listening to this episode of Overtime. We hope you enjoyed our conversation as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, or wherever you get your podcasts to stay up to date on all things sports medicine. You can also watch some of our episodes on YouTube. If you like what you hear, please consider subscribing and leaving us a review. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.